Hello, my name is Ruben Major, and I am a paramedic, instructor, program director for Arizona, and the chief executive officer for EMS University. Today we're going to be discussing incident command and mass casualty incidents. What is a mass casualty incident? Well, a mass casualty incident really is any event that places excessive demands on personnel or equipment that's on hand. So this could be anything. Some particular jurisdictions will define mass casualty incidents as having over a certain number of patients. And for local protocol, again, it may vary. But in all reality, what happens with a mass casualty incident is that it taxes the system. So we have to find a way to manage these situations that's as effective as possible. The most type of common, or I guess the types of common mass casualty incidents include highway accidents. Highway accidents by far are the most common MCIs because they occur on such a regular basis. And this is uh, especially true for your locality if you have a large highway that has a lot of traffic running through it on a regular basis. The more cars that there are traveling on the highway or even on the interstates, you're gonna find a lot of these issues. And then also airplane crashes, although they don't necessarily occur on a regular basis, when they do occur, they are pretty dramatic. And if you have a major fire, you're going to have a lot of issues to deal with, command situations, as well as there's a possibility that you might have mass casualties. Train derailments is another one. They've had a few recent train derailments. Fortunately, they're managed very well. And then building collapses, those can be quite difficult to deal with. And then apologize for that. And then hazardous material releases and earthquakes, tornadoes, hurricanes, and floods. So natural disasters. So what do we do to prepare for the incident? Well, what we do is, and I always thought this was kind of a cheesy word in EMS and fire, but this pre-planning. In all reality, it's just planning. So we plan and prepare for the incident, and what that means is we're going to take precautions to make sure that we're prepared in the event that the incident does occur or that there is a problem with mass casualty in the area. So what do we do? Well, we do lots of training exercises. We do education on those events. We should be studying other areas or localities where they've had incidents or mass casualty incidents. And then we should be also critiquing our mass casualty incidents to make sure that we're doing them appropriately. And it's really not a bad idea to go through and do a formal critique of what you're doing on a regular basis as far as your mass casualty incidents, because that's how you're going to get better. And I'm not just talking about a pat yourself on the back critique. I'm talking about a real valid critique, because if you can go through this incident and you can find a way to get even better, it will make the next calls go so much more smoothly. Scene management is a must. You have to be organized when you are at a mass casualty incident. Post-disaster follow-up. Again, we just kind of talked about this a little bit, but scene critiquing is very important. It's also part of a quality assurance, quality improvement program as well. So, pre-planning phase one. Well, pre-planning includes frequent drills with multiple agencies to work together to better handle these incidents. So again, how are these multiple agencies going to work together when they get on scene if they have not established a rapport, if they have not figured out what a typical chain of command scenario is going to look like, and how they're going to work together as providers? they're going to have a very difficult time managing the scene if they're just meeting and greeting with each other for the first time on a big mass casualty incident. There should be a written plan for all responding agencies, their duties and all the other needs that they might have for incident management. And not just duties, but what are the agreements? Who's going to be working on what? And if it's a certain type of situation, is there one agency that might be better equipped to handle certain types of tasks or the entire scene even than the other agencies? So these things should all be taken into consideration even way before the incident ever even occurs. The second phase of scene is going to be scene management, and scene management really begins with setting up an incident command system. When you set up an incident command system, it really helps to make sure that things are organized. But also remember to know and understand what a mass casualty incident is. A mass casualty incident is an incident which taxes the system. So if we set up an incident command system that's too big to manage the scene that we have, we'll end up having a management problem that makes the scene last longer. The dispositions of patients will take longer to get off of the scene and to the hospital, as well as trying to delegate that authority will be very difficult to do because you'll just have so many people and they may have idle tasks. So very, very important to know what your protocol is and take into consideration when it is actually necessary to set up an incident command system. It is always better to be safe on the safe side than to not. What is ICS? Well, we've talked about it a little bit, but it is a standard management system to be utilized handling all types of emergencies to enhance emergency worker safety and effectiveness. Now, an incident command system should be very flexible. So you should have the ability to really expand and contract it. And that's kind of what I'm just talking about in the previous slide. So you'll want to make sure that when you have an MCI or you set up command, that you have the appropriate number of resources for the incident that you are dealing with. And it's always good to have those plans in place ahead of time so that you know exactly what you're going to be calling for. The components of ICS include having a common terminology so that you can understand all the units that are going to be responding to this particular incident. It's very important for you guys to be on the same page, so plain language is very important. A modular organization. Integrated communications is always helpful. If you have some people that are on different radio channels, you may have issues with trying to communicate. In those cases, it's not a bad idea to have a liaison officer from each particular agency, perhaps within earshot of each other, even sitting in the same vehicle, managing the scene together, because it just will make that operation of that incident go so much more smoothly than getting in and out of the truck or getting in and out of, or walking back and forth trying to figure out what you guys are going to do. Setting up a command system is important. It's very, very important to make sure that whenever you do a command system that you have a chain of command that's followed and that you have a unified chain of command where all of the agencies are happy with the way that things are going and working. Consolidated action plans are very good. Again, unifying that command. Manageable span of control. So making sure that you don't have too many units for each officer, or making sure that you don't have way too many personnel that are overseen by one supervisor. And we might call it one thing or another. The standard terminology is really just varies depending on whatever the jurisdiction is or the area is. But really, a manageable span of control is going to be about 5 to 7 people or 5 to 7 unit per officer. So keep that in mind so that you can keep things more organized. If your incident grows, then obviously you're going to want to make sure that you have enough supervisors to take care of uh, those new issues. And then also remember that if your incident is really, really big, you may need to have people who are supervisors of supervisors in order to take control of the situation and more effectively delegate the authority. So, and we'll talk a little bit more about that here. Designated incident facilities. So, which hospitals are they going to, or where exactly is the patient going to be dealt with? What are the comprehensive resource management? So, we need to know what exactly is happening as far as the availability of the emergency systems in the area. Communication, again, we talked about this. Do not use 10 codes or any other codes when giving command, because you really want to make sure that everybody knows what you're talking about. And the easiest way to confuse people is to start using 10 codes, because 10 codes can most absolutely definitely vary according to agency. And that might end up creating liability on everybody's end as well. So just something to think about. Do most of your communications face to face if you can, and have a unified communication system. There should be a command frequency, and this is where all of the officers that are dealing with the incident are discussing the incident on the same frequency. This is very important to minimize the chatter where you might have other units that are responding to different calls, or say they're clearing a scene, or they're clearing the hospital, or they're going for training. You don't need that on your incident channel. Or you don't need that on your incident channel. So, likewise, also ask for an incident channel in the event that you might need one. Modular organization. Well, again, that's the ability to expand or contract the command system, and it's being used to fit the incident. So, again, we talked about this. Just make sure that what you have is a manageable span of control, so that your incident is managed most effectively. This particular modular organizational chart is just kind of this is at the very top, and we're talking these kinds of things. Actually, you won't see an officer for each and every one of these roles on a small incident. However, a person who's in charge may be fulfilling several of these different tasks at any particular given point in time. However, when these particular things become unmanageable, that's when somebody needs to be delegated to these specific tasks. This is all about effective supervision. So normally, with a smaller incident, in a medical sense, you'll have your incident commander, who may also serve as operations, and then you have different operational things that need to be taken care of. Again, technically, there is a logistics planning and administration portion, but they're at such a small level that it's not really necessary for us to really delve into it on a small scene. For a bigger scene, most definitely you're going to have people that are fulfilling all of these particular roles. And a lot of times you'll see, if it's one agency that's taking control of the situation, it's really more standardized with their particular chain of command anyways. So if we're looking at incident command structure for EMS in particular, we have the incident commander, the operations branch. So again, operations is what is it that's going on exactly at the scene. So we have an EMS branch. We could have a fire department branch. We could have a police department branch. We could have a public works branch or a utilities branch. All of these other things could be out here. But specifically discussing, apologize for that, but specifically discussing the EMS branch, we'll have a triage unit, a treatment unit, transport unit, and staging unit. For the triage unit is going to be the officer that's in charge, or the supervisor that's in charge, whatever you want to call him, of the triage personnel who are out there basically categorizing patients for priorities. And then also under here you can have the morgue, or you can have, somebody's going to be supervising, well, what do we do with, all the people that are deceased on the scene. And then for the treatment unit, you have minor, delayed, immediate treatment, and all of these particular sections could be put on a tarp or section to a particular area so that you have an officer that's controlling each three of these areas. Again, this is thinking big, gigantic scene. Now, in a smaller type of scene, what you might see is an incident commander, a treatment officer, and an area where the treatment's being done. So this is really flexible, and it's important for us to keep that in mind. The transport unit, the transportation, maybe is what it's called, is going to be responsible for making sure that the units transport appropriately. Where are they going? Be in communication also as well with these particular areas, such as the air ambulances, the medical communication, additional ground ambulances. Say if you're running a scene and you're not with an ambulance agency, who's going to be doing the communication with them? And then if you're a staging unit, so you have a staging unit, so a staging officer or supervisor is going to be in charge of making sure that the ambulances are in a place, and the air ambulances or helicopters, whatever it is that you're using, are in a place where they're not going to clog up the scene, because that can present or pose an issue as well. And that's also something for the transport unit to keep in mind as well, and for operations to keep an eye on, because sometimes there may be limited access to a scene, and so it's always very important for us to make sure that when we have limited access, that we have units staging at a particular area so that they're not clogging up the egress of the incident. So again, I hope this very brief presentation regarding EMS ICS structures been helpful to you so far. Managing the span of control deals with the number of personnel, any individual's direct control. The ideal range is 3 to 7, and I had said 5 to 7. Ideally, it would be nice to have about 5, but in all reality, you end up usually taxing at about 7, which is unfortunate, depending on your agency, of course. I worked for a rural agency, and we had I would say, a higher manageable span of control than the typical city area. But you should probably try to stay around 5 if you possibly can. Designated facilities. Is there easy access to these facilities? What is their communication capability? The equipment on hand or computer capability, and is there reference material available? So who is in charge here? Again, when we talked about planning ahead, it's important to make sure that there's agreements in place and there's policies that are actually happening when an incident happens, so that people know who's in charge or who's taking care of the situation. The incident commander is the individual or group of individuals who oversee the incident. It is not always the first on scene or the senior person. Technically, it may be for a brief few minutes the first person that's on scene, but in all reality, what is going to end up happening is whoever the first is that's on scene is going to end up passing it off to somebody who's more experienced or equipped to deal with the situation. It should be the person who can organize the personnel and equipment most efficiently, and usually this is done through delegation of authority, whether it be by agency or within that particular agency. There may be certain officers that are responsible for managing the scene. And when I say officers, I'm really talking about somebody who's fulfilling a role. So this could be a supervisory unit, a battalion chief unit, or anybody within a management type of position, serving as the incident commander. And here's another problem they run into. Well, where do you want me to go where? Well, there should be several sectors established to manage the situation. So whoever is managing incident command needs to make sure, or whoever's acting as an incident commander needs to make sure that whenever an incoming unit comes in, that they go to the appropriate place. So there should be a standard policy and procedure that's set out so that that person goes to the correct place. There should be several sectors established to manage this situation. Um, Not necessarily always, but we're talking big mass casualty incidents. So when we're talking these big mass casualty incidents, remember who is it that's going to be going into what particular sector, group, or area, and who are they going to be reporting to? Because the last thing you want is to have 20 units come into the scene and everybody is reporting to you. They all need to be reporting to a particular section so that you keep the incident as organized as possible. Each sector should have an officer or oversee the operations and report to IC. So just like I said, and the officer must be strong and at a supervisory level and able to not get involved in the incident. So that is the worst thing that you can possibly do as a sector officer, is get involved with that particular sector or that particular group or area. And what I mean is, just as an example, let's suppose that you have a treatment officer that's going to be responsible for 15 incoming units. That's a huge span of control. We can say, just for the fun of it, let's say five units are going to come in. Okay, not 15. So let's say 5 units come in. You have a treatment sector officer that's in there that's responsible for making sure that those 5 people that are coming in, those 5 units that are coming in, are doing their jobs. Well, let's suppose that treatment officer just decides to start jumping in and treating patients, and then the units will come in. Well, this can be a problem because when the units all start coming in and that treatment sector officer is not available and working with patients, there can be a problem with, well, where is it that these particular units are supposed to go? Who are they supposed to talk to? They may be off there just kind of trying to figure out what they want to do. The incident won't get managed as appropriately as it needs to. There may be re-triage done. There may be incidents, or there may be work that's redone that didn't need to be done. So it can really destroy things in a command situation where you have sector officers that are working on things within the sector and not actually managing the sectors. So the sector officer is a manager. It's a supervisor that's in charge of making sure that things operate efficiently. It is not somebody who's supposed to be involved with the incident. You have staging sector. We talked about this before a little bit. It's a safe haven for personnel and equipment. Should be within 3 minutes from the scene. Sometimes this isn't possible. Sometimes you may need to go a little bit farther. It just really depends on the situation. And it is very important to the success of the incident for the reasons that we discussed before. You have level 1 and level 2 staging. You could have staging that's off-site and away, or you can have staging that's very close. Treatment sector. Again, this is the area where the triage patients are brought. Patients are given tags to show their treatment priorities. And, well, who goes where? Well, we have a start field guides, and what that stands for is simple triage and rapid transport. And basically what you'll see is, I'm just kind of fast forward a little bit so you can see what the deal is here. So you have green patients, you have yellow patients, and you have red patients. And then you have black patients. So these are all different categories. If you just take a look at here, you've got the black is the deceased, the green is the walking wounded, and the yellow is the immediate, or excuse me, the yellow is delayed, and the red is immediate. This appears to be somewhat of an error. But in any event, that should be red right here. But in any event, this is all, these are all kind of your general triage tags. And actually, here's what the tag looks like itself. This is a tag that's going to go on the patient, be wrapped around them. When you have an immediate, which is a red patient, you're going to want to put an immediate sticker on them or in the area so that people know that this is a person that needs to be transported as soon as possible. So let's go back here. Simple triage and rapid transport. So it is based on your ability to walk, your respiratory effort, pulses and perfusion, and neurological status. So ability to walk. Well, ability to walk, if they can walk around, that automatically makes them a minor patient right off the bat. So if they can walk around, they're a low priority patient. In fact, they're not the lowest, but they're going to be the lowest patient that you're going to deal with the exception of dead. Respiratory effort, you know, there's different protocols for this depending on the area, but this is going to be a category that you're going to use to try and make a define between whether it's a patient that needs to be immediately transported or whether it's a delayed transport. If their pulses or perfusion isn't very good, they're going to be more considered to be an immediate, and if their neurological status is altered, they're going to be considered to be immediate. So, and we have this right here too. This is a nice little flow chart. I'm going to just take a second to take a look at this. Just remember that this should be red. So here, if you open the airway and they're able to breathe, they're immediate. So, but if the airway is, if there's no initial respirations, and then you can kind of go through these ones right here. You can pause this if you want to take a look too. Okay, and meta tag cards. Well, we just talked about what these were. Or met tag, sorry, met tag. And here's what the card looks like. Why would you use the met tag system? Well, basically it alerts providers to what the patient priority is. So, and this will help too. This is one of the things that's very important for the treatment officer to do, or the treatment and triage to work together to show what patients are priority and which ones are going to need to be transported more rapidly. You're going to prevent the retriage of the same patient, and it serves as a good tracking system. You know, it's a substitute for a patient care report in a mass casualty incident because you don't have enough time to write a patient care report. You really need to just get to work. And in the court of law, they're gonna really take a lot more leniency on you because there's so much more going on in the scene. There's only so much you're capable of. So, and this is a good standard protocol to follow. So where did all the patients go now? Well, the transportation sector works with the treatment area and local hospitals to coordinate transportation of the patient. So we talked about that. They set up they landing zones as well. So they might, they'll call themselves transportation or LZ or landing zone. But that's basically the function of transportation. They make sure that there are means of transportation available at all times. So they're going to be coordinating things with the local hospitals and trying to find out how much room is available at these particular areas or these particular hospitals so that patients can be transported. And sometimes, unfortunately, when the resources get so taxed, or if they're already taxed, then you have a mass casualty incident, you're really just going to have to do some bargaining and find out which the best places are to send all of the patients. You don't want to load up any one particular hospital when you have a very mass casualty incident. So you're going to want to be talking to these hospitals to make sure that you're sending people in a place where they can be treated as quickly as possible and discharged if they can be, or sent to more acute care later on. Uh, Helispots and heliports. Helispot is a temporary landing zone. Heliport is a place where they land on a regular basis. Often this is where the helicopter can get refueled and be maintained well. Helispot is going to be the temporary landing zone. So we call them landing zones as well, but just something to keep in mind. So setting up a landing zone is kind of a somewhat of a complicated task, but it really doesn't have to be. The idea, though, is to make sure that you are being as safe as possible and looking out for all of the providers in the area, looking out for everyone to make sure that nobody gets injured, because that's your job as the landing zone coordinator. So make sure that the landing zone is clear of any obstructions first and foremost. And what are some things that could be an obstruction? Well, is there something on the ground that's going to make it difficult for the helicopter to land? Is there are there power lines that are going to be in the way? That's a big one. And if there are power lines that are in the way, you need to make sure that you communicate this information to the helicopter, and just so that they're aware of the situation and they don't end up crashing into them, and then you have many more patients. The other thing is to make sure that if you're using a divided highway, to stop traffic coming from both ways. And the reason why we do that is because we don't know what the people are going to do that are driving in their vehicles. If the highway is stopped, traffic stopped in only one lane or in one area, you may end up having a problem where people are trying to get around, and that's the last thing you want. So you gotta make sure you have the appropriate personnel, or the people out there making sure that these sorts of things don't happen. Look at what the wind direction is, and how fast is the wind moving. Is that going to play a bearing or factor on how the incident is taken care of? Mark each corner of the landing area with a highly visible device. So this could be with a flare or any other kinds of devices. And also another device might be, a cone. Just those different sorts of different bright colors are important. Okay. And then also consider the wind direction. Oh, I already said that. Put the fifth warning device on the upwind side so that they know, where the upwind is. And then keep the patient and crew clear of the downwash area. So the backside of the helicopter is probably the most unsafe area. And if you've been in any of these scenes, you know how dangerous that back area can be. You can easily take someone out if they're very close to that area, because they can't even see it, and you can suck them in, and then then you have another patient or issue to deal with. And then assign one person to guide the pilot in. Give primary care to the patient and follow the instructions of the pilot. So important to keep a good communication with them as well. Finally, for landing, continue to be cautious of rotary blades. Never approach a helicopter till the pilot says it's safe, and they'll give you the go-ahead just to tell you that it's safe. Secure all the loose items that you possibly can. You don't want anything flying up into the blades and getting caught, and then picking up a patient or picking you up. Secure all the loose items again. And no one should smoke within 50 feet of the aircraft for obvious reasons. Approach the helicopter from the downhill side, and never point spotlights up at the helicopter when it's on its final approach at night, because they won't be able to see. Now that all the patients are gone, what do? Well, you return all departments and equipment to service, so make sure you assist with cleaning and getting everybody ready, asking what they need, and helping them to be able to go to the next call. Make a written report from all responding services of how the incident went. This is important also to have everybody briefly at the scene, whoever was in charge of those particular sections get together, or anybody that was left get together and just kind of discuss the positives, negatives, and rooms for improvement on the scenes. Very important to make sure that whenever you do these, they're honest and that you have a mind's eye out for improvement. And then also doing written reports later on these and talking about them and doing quality assurance and quality improvement will improve your department overall and the mass casualty response in the future, and identify any issues that you might have that you can improve upon to increase the efficiency of what you're doing. Because it's all about efficiency. When you have a mass casualty incident, you have limited resources. So using your resources as efficiently as possible during a mass casualty incident is the best thing for the entire system. Have a critical incident stress debriefing for all your responders. If it is truly a mass casualty incident, you will absolutely positively want to have CISD available for your responders to make sure that they are doing and they're feeling okay about everything that went on in the scene, and if they're not feeling okay, getting them the help that they need and also discussing the issues does help. Make available the written report to all services. So very important for everybody to be successful in this, for everybody to take a look at the written reports or items that were made as a result of the incident. And then ready yourself for the next mass casualty incident. And that will do it for this section.